So much, Carly. Welcome everybody to our session. Just a brief reminder that this course is presented solely for information purposes, and so the opinions presented here do not necessarily reflect those of the Canadian Medical Association. This session is on influencing up. How do we affect change at all levels of training and career stages? I'm Dr. Katie Lynn, and along with my co-host, Dr. Yan Yu, we'll be taking you through some principles of influence and what it means to influence up. We're also fortunate to be joined by three esteemed guest speakers who bring a rich lived experience to the table, and we look forward to introducing them to you later in this session. I'd like to begin with a land acknowledgement. And so we begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we all call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nation people that call this land home. And thank you to all of you for taking time out of your busy schedules to join us for today's session. We hope that it'll be useful for you. These are the four key objectives we'd like to equip you with throughout the session. Number one, to understand what constitutes influence. What does that look like in our medical context? Two, to review basic strategies for generating influence. Three, how influencing up specifically differs in terms of its strategies, common mistakes that we can encounter. And four, to understand what influence looks like through case examples and discussions. Just a brief introduction so you know what context I'm bringing to this session. I'm a Royal College trained emergency physician from Calgary, working with the Foothills Hospital. I also work as a flight transport physician with STARS Air Ambulance and with the Calgary Stroke Program as a stroke physician. So I love brains and I love medical education, and it's an honor to be part of this session with you. I'll let my co-host, Dr. Yan Yu, introduce himself as well.
Thanks, Katie. I'm Yan. It's nice to virtually meet everybody. I look forward to chatting with all of you. I am going to be monitoring the chat too while folks speak. I have been involved in a lot of influencing up, I guess, events or causes, let's just put it that way. So this topic is very near and dear to my heart. I'll specifically be using the Calgary Guide to Understanding Disease as an example. I founded that this is a medical education tool for free online in 2012, and right now it's used by 3,000 people on average every day around the world. So I'll be talking a little bit about that, about the journey. But yeah, I'll hand it back to Katie for the session.
Thank you. For disclosures, other than the honoraria we've received from CMA Jewel to prepare and deliver this presentation, we have no other disclosures to share. So as we set out on this journey together, here's just a quick roadmap for the next 2 hours. We're going to start with introductions to the concept of influence and influencing up and how that applies to us as medical providers at various stages of our careers. Next, we have an esteemed panel of presenters who will share their stories of how they've utilized principles of influence to create change in their own organizations and teams. And finally, we'll close with a Q&A panel discussion where you'll have an opportunity to ask any questions that you might have of our panelists or myself or Dr. Yu. Some housekeeping elements. Please mute yourselves if you are not actively speaking so that we don't have any audio interruptions. If you are able to, we'd love to have you turn your cameras on to maximize our interactions with you this evening. Being able to see how you're reacting can really help us to tailor the content for you. We'll pause throughout the talk to go over any questions that come up, especially in the chat box. So please do feel free to enter any comments or questions into the chat box as we go, and either Dr. Yu or myself or any of the speakers will be keeping an eye on those. Also, feel free to use the raise your hand feature, and we can call on you to unmute yourself to speak as well during the Q&A sessions. And finally, as Carly mentioned, this session is being recorded and will be available through CMA Jewel's YouTube page after the talk. This is the first time we're running this session on influencing up. So if you have any feedback for us, please let us know at the end so we can continue to improve this content for you. In order to talk about how to influence, we first have to talk about what influence is. And to that end, I'd just like to begin by sharing a story. How many of you know who this man is? And if you do, please pop it into the chat box. I'll give everybody maybe a couple seconds here. For those of you who don't know him, this is Martin Bromley. Martin Bromley is not a doctor. He's a commercial airline pilot, and yet he's had a profound influence on the modern culture of patient safety in medicine. In 2005, Martin's wife, Elaine, underwent what was supposed to be routine elective sinus surgery. Shortly after her anesthetic induction, her airway obstructed, and attempts to bag valve mask and place a supraglottic airway failed. For over 20 minutes, Elaine's oxygen levels were about 40%, and ultimately she passed away in the ICU of hypoxic brain injury. Martin Bromley insisted on a formal investigation to understand what had happened in his wife's case and how it might be avoided in future. But most importantly, as a commercial airline pilot, Martin insisted that the investigation was focused on the system-level failures that prevented a well-equipped, well-trained team from responding in an organized way to the unexpected failed airway case. Martin did not seek to blame individual providers for what happened to his wife, but rather to highlight the flaws within the system that needed to be fixed in order to help all future patients avoid the same outcome. He basically translated his experiences with commercial aviation's system-focused safety culture into the world of medicine, where it didn't widely exist before. And in so doing, he's influenced our very understanding of patient safety in medicine. Martin and Elaine Bromley are the reason we now routinely use checklists pre-op, pre-sedation, and pre-intubation. It is the reason we have algorithms in place for high-risk rare events. And so Martin Bromley is not a doctor, but he has had a profound influence on how generations of doctors have been taught to think about patient safety, including all of us here today. Influence is the capacity to have an effect on the character, development, or behavior of someone or something. And the truth is that modern medicine is truly a team sport. We work with various specialties, allied health colleagues to coordinate the complex care needs of patients within a large system. Nothing happens in a vacuum, in healthcare or otherwise, and so we're all connected by that complex network of care. And therefore, our actions and decisions have an impact on those around us, whether directly or indirectly. It's important to note that influence is not the same as power. Power is the authority to compel other people's behaviors or perceptions, and usually comes from some sort of hierarchical relationship. Whereas influence is the ability to alter other people's perceptions and behaviors and encompasses a much broader concept of how we can impact those around us. Influence does not necessarily require or rely on a hierarchical relationship to function, which our speakers will talk to you about later today. We've talked about what defines influence, but how do we actually operationalize it? How do we exert influence? Well, the skill of influence requires a combination of interpersonal communication, presentation, and assertiveness techniques. And like any other skill, it can be practiced to help achieve your goals in your career and your organization. It's important to remember that there is no one way to influence. Rather, it's about reflecting on your own values and strengths and finding your own style to navigate some of those challenging interactions. You'll get to hear about a variety of different influence styles with our speakers. And first, let's review the 6 principles of persuasion. These are fundamental principles of human behavior that are likely to apply in any situation where you need to interact with others in a way that moves them to act. The first is mutual respect or liking. This is where people are more likely to say yes to people they like or respect. Factors that can impact liking include physical attractiveness, similarity like shared interests, perspectives, or experiences, genuine praise, and it's important that it be genuine for it to come across in an effective way and to genuinely create that bond, and familiarity, so repeat interactions, mutual connections, and association with positive things. The key here is to find common ground, to cultivate mutual respect, and to like or at least to see the positive in the other person. That's what creates the trust and therefore the influence. 2 is reciprocity. So people tend to want to return favors. This is why salespeople give us free swag and corporate executives take clients out to fancy lunches, but it doesn't actually have to be monetary to be effective. When my charge nurse and I compliment each other on our awesome new scrubs, we actually feel closer to one another instantly. But this also means that we tend to reciprocate how we're treated. So again, treating others kindly will generally return the favor. 3 is social proof. This is basically that idea of going with the flow or part of something bigger than ourselves idea. When we see a lot of other people doing something, our brains generally view it as more acceptable, more normal. This can be a good or a bad thing. On the one hand, we can use this principle in a positive way, such as normalizing respect for alternative pronouns like they or them for transgender patients. This can also be used in a negative way, such as dismissing microaggressions or perpetuating harmful stereotypes. At a change leadership level, it's important to be aware of this principle because it means that influencing change that aligns well with how things are already being done in your organization is going to be much easier than influencing change that represents a significant departure from how things have always been done. 4 is consistency. People tend to try and act in ways that are consistent with their earlier words or commitments. For example, if you get someone to commit to participating in a project early on, they're much more likely to continue to follow through on that commitment later, especially if they're reminded of that earlier commitment. And this can be helpful if you're leading a group, but it can also be helpful to resist this psychological urge if you realize that your plate is too full and you need to set some boundaries around your own workload. I think we've probably all been there and or are there at present. 5 is authority. So this one's pretty self-explanatory and kind of goes back to that power concept. Those in positions of authority generally have more influence over decisions because they can leverage or compel behaviors. But it's important to know that authority doesn't only refer to an official position or title like program director or department head. It can also refer to expertise. So for example, a resident representative on an educational committee is very much the expert on what the resident experience is like, and so has the authority to speak and make suggestions within that sphere of influence. And finally, scarcity. People feel pressured when opportunity is less available. This is where the salesperson is telling you that the sale is a flash sale only on for a limited time, or that's only a limited number of spots left for a particular position. At a change leadership level, this can look like framing an initiative as a select opportunity for a small group of motivated people, and then trying to find ways to reward them for their time at this point. And so with that, I'm actually going to be handing it over to Dr. Yu to talk a little bit about how influencing up might look different from influence in general.
Thanks, Katie. That was awesome. And thank you to Nikita for turning on your video. It's great to see you. And I encourage any other brave souls out there to turn on your cameras. We're a very small group here, just 5 presenters and 14, 15 attendees. So this is quite a good group of folks. So yes, what does influencing up mean and how does it compare with influence? Well, from my very layman's terms, non-technical definition, I would define it as just trying to influence or trying to convince somebody of some course of action or way of seeing things from a position of lower or less authority, maybe as a junior member of the medical team. But then how do you influence up? So Katie, next slide, please. It really depends on the context in which you're doing so. So I want to preface everything that I'm saying here by saying that the context that I'm going to be presenting here in this section specifically refers to the medical schools, residency programs, academic departments, universities, or within small patient healthcare teams. In governments or in business, these principles may be similar, but the strategies will be different. And this is also based on my own personal experiences, and I'm definitely not a total expert or PhD on this. I definitely have a lot more to learn about this as well. So I do look forward to what our speakers will have to share regarding their influence and their lessons and learnings. In general, though, influencing up really presents a unique set of challenges because the 6 principles of persuasion often fail. So for the first one, mutual respect, where you take time to find common ground. They're busy people, the people you're trying to influence, they're usually in high up leadership positions, and they often don't have time for you to build common ground with them. And the second principle, reciprocity, they can do a lot of things themselves. They have teams of people working for them. They don't need you to do them any favors. The third principle, social proof, they are the proof. They are the people who set the rules, who determine how things are done. And often, when we're trying to influence up, we're tasked with the difficult challenge of doing things differently compared with how things have been done. And this, unfortunately, goes against the social proof concept. The fourth principle, consistency. Humans, as in general, like to be consistent with what they've done in the past, and senior leaders especially oftentimes like to be consistent with their initial decisions that they've made. And so they tend to resist any sort of proposed changes from underlings. Fifth principle, authority. Definitely, there are many times when we have absolutely no authority whatsoever. I was the resident rep actually for in residency. And I can definitely recall a time when I was at a meeting and I was speaking with one of the senior management, and they specifically said to me to not annoy them anymore in the course of the meeting itself. And I don't think I was actually presenting anything annoying or close to that. But yeah, so unfortunately, we are at a disadvantage here in terms of authority. And the sixth principle here, scarcity. So the scarce resource tends to be money, but it could also be time. For the example of the Calgary Guide to Understanding Disease, it was server capacity and the ability to create a website that can be that we can use to share our resource with the world. So and there are these difficult things that we encounter when we try to influence up. So, but you know, we try to do the right thing. We still are compelled to actually make these changes that we want. And sometimes, next slide, please, it can be a very, very difficult task. And not only because you're not seeing the changes that you feel are necessary, but because it creates a sense of powerlessness in you. And so and there's nothing that leads to burnout faster than a sensation of powerlessness when faced with a need. But it's very common for us as early career physicians, as driven, motivated early career physicians, to feel that way. But there can be something that can be done about it. And so next slide, please. What I discovered when I was doing these influencing up things was, first, we have to make sure that the cause is the right cause, that it actually would benefit as many people as possible, and not just someone's own pet project, for instance. And that means picking battles wisely, and standing up for the wrong cause might not be effective from a societal standpoint, but it may also be a waste of your time and energy. It may also destroy your social capital. And the second idea is when you would carry out your influencing up actions. Your timing is critical here, and think about, is this change something that must be done right away, or maybe it might be better to wait for a more opportune time? Don't assume you only have one shot at making the changes that are necessary. If now doesn't work, and even if a few months from now doesn't work, there may be more opportunities to come. The third idea is something that I learned from one of my mentors, Dr. Ewan Affleck. Dr. Affleck actually is an Order of Canada recipient. He worked hard for 10 years to organize the entire Northwest Territories EMRs under one single EMR, so that when I'm working up in Fort Smith, the specialists in Yellowknife can actually see everything that I'm doing. So when he was talking about influencing up, one idea that he had is, who are you trying to influence, and can they actually make the change happen? Oftentimes, people who you think are in charge and who you think are calling the shots are just stabbing in the dark like the rest of us. Because once a system is set, rarely can individual people in high position, even if they're in high positions of leadership, rarely can they change things, even if they wanted to. So, of course, some people may have more control or impact than others. So you got to be sure that you are talking to the right person. Okay. Now, when you're sure you've found the right cause, it's at the right time, and you've picked the right people to influence, now you're ready to act. And when you're ready to act, it's important to avoid the common mistakes. And so, and I know they're common because I've actually made all of them. I guess they can be uncommon mistakes as well, and I probably would have made them too. But the first one is, when I have a cause, I'm very passionate, I'm very committed to that cause. But sometimes I could also give in to that passion and give into that emotion. And so the idea here is, no matter how strong your conviction, it's important to keep in mind that the conviction of the person you're trying to influence is equally as strong, if not stronger, and you will not get your way just with passion alone. The second concept is fairly self-explanatory. Obviously, respect underlies everything that we we have to do as change makers. The third concept is I put in brackets, and it's actually based on a YouTube video about the above the line or below the line concept, where going above the line means that you always assume positive intent, and going below the line means you're assuming that something that other people are saying or other people are doing have negative intent. So try to always assume positive intent, never assume badly of other people. And the fourth is doubting yourself, because it turns out that if you behave like an outsider, or if you behave like the cause that you're advocating for isn't going to happen, chances are it's not going to happen. It's kind of like the Pygmalion effect that way. So, all right. So we talked about the common mistakes. What are the actual principles that I've learned to make change happen over time? The first is standing your ground. So basically, when you have a cause that you're sure about, you stand your ground, but you got to keep the high ground as well. You can agree to disagree politely, and be genuine in your good intention. So for me, when I started the Calgary Guide, I actually created a survey to survey all my classmates about it, to look for the nuggets of good ideas that I know will make the project better, even if it was difficult for me to hear. But there were a couple of other comments, such as one of the comments, it went something along the lines of, someday, Yan, you will realize we're not laughing with you, we're laughing at you, or something like that. You really have to work hard to actually not let those things affect you, especially when you're trying to work on a cause. And so I was fortunately able to take some nuggets of good ideas out of that survey, regardless of comments like those. Second concept is just make it about them. Do your homework, figure out what they need. And the need can be something that even they didn't realize that they needed. And then give them what they need. And so using the Calgary Guide as an example, we've all been through med school. You've all sat through lectures of lists of signs, symptoms, clinical findings, and none of those lists, that at least the ones, or few of those lists, are rarely have ever explained well at a basic level, at a medical student level, that's sufficient for full comprehension of those topics. And so what the Calgary Guide does is it actually translates those lists into flowcharts, and using concise and very simple language explains the basic pathophysiology underlying the signs and symptoms of disease. And so we gave it to the med school, we gave it to them for free. This is beneficial to the students, to the lecturers who now use our slides, and also it's beneficial for the reputation of the university as well, because now, just as one example, the medical school consistently uses the Calgary Guide when promoting the school to candidates during med school interviews. Third idea, again, self-explanatory, work your butt off, work harder than everybody else. This is a very thankless task, but often necessary. So when I was building the Calgary Guide for about a year, I took no breaks. I was just a hermit. I was working to produce the content. But this is good because it shows the people who you're trying to influence that you're being serious and that you're committed over the long term. That's how you get respect. And last and perhaps most important, you don't get anywhere with a social change initiative by yourself. You join with like-minded people. There's strength in numbers. And working with the Calgary Guide folks, I had a great team. It would not be anywhere where it is now without amazing teams of students and faculty and our UME medical school administrative collaborators. We have about 30-40 students work on the project every single year. And I've actually found that if you work with others, it can oftentimes correct the many mistakes that I make. So that's it for me. I will turn it over to Katie to introduce our brilliant speakers. I hope we're not too behind on time. Thank you.
Sounds great. No, we're doing well on time. And so just as a reminder to wrap up our intro section, none of us get to where we are alone. We rely on those around us to achieve our personal and collective goals. So understanding the role that influence plays and some of the tools available to help us grow the skill can help us be better leaders and advocates of change within our healthcare systems. I don't see any questions in the chat, so I'm going to jump right into introducing our first speaker, Dr. Monty Ghosh. Dr. Monty Ghosh is an internist, disaster medicine, and addiction specialist who works at the University of Alberta Hospital in Edmonton, as well as the Foothills and Rocky View hospitals doing addiction medicine in Calgary. He works with multiple community-based, not-for-profit organizations to provide support for marginalized populations, such as those experiencing homelessness, substance use, mental health concerns, as well as those who are in corrections. He's an assistant professor at both the University of Alberta and the University of Calgary, and is heavily involved with provincial policy building in Alberta, as well as with research. He was a CMA Young Leaders Early Career Award winner in 2021, wears many, many hats, and I'm very excited to have him speak with us today. Handing over to you.
Thank you so much, Katie. I really do appreciate it. And I'm trying to see if I can share my screen here. Again, thank you so much for having me here. As part of the discussion, if anybody has questions, feel free to jump in and ask those questions. I really liked both what Katie and all of a sudden my screen is not working right now. Hold on a second here. Can you guys see my screen? Is it working?
We can see keep calm and hack the system.
Yeah, that's what I'm seeing as well.
Okay, for some reason it's not showing up on me. Maybe I'll stop sharing for a quick sec, and then try to share again.
I think we just saw your starting out slides.
Okay, and I can see it now, so we're perfect. So yeah, no, first of all, thank you, Katie and Yan, for like doing the introduction like that. There's a lot of nuggets that I learned off of you guys right now as well. So I really do appreciate that. So yeah, my presentation is basically like keep calm and hack the system. And I think that's very much what I've tried to do with the last little while. I've had to sort of struggle with influencing and I've learned a lot. And one of my mentors told me that, when there's a will, there's a way, and you gotta hack the system. For those of you in Calgary, that's Martin Labrie. He's been a huge mentor to me, and that was his big thing that he kept sharing with myself. So just a bit about me. When I first moved to Calgary from Edmonton, and I work in both cities now, I do internal medicine at the U of A hospital in Edmonton, but initially I moved to Calgary because my father was sick, and I had sort of a fresh start in Calgary, so to speak. Didn't really know anybody, didn't know who to work with or where to work. Didn't have a job when I first showed up as well to the city, and just kind of just started working in the community. And it was tough. It wasn't easy. I had to move to Calgary because my father was sick. I had to be close to him. He was going through chemo at the time, and so it was a rough ride. But at the same time, when you start off and you just graduate and you don't have any existing jobs, like what do you do with yourself, right? Like how do you reach where you want to reach in your career and do what you want to do? And so I started, the first job I found was actually at the inner city, and it was the Alex Community Health Center. And I started working with them. And I remember starting off feeling a lot of shame. And the shame I felt, I think, was because I felt that I didn't have a glamorous job at a hospital. I didn't have a university appointment. I had no influence. I had no power. And I felt like there's things that I wanted to do, but had no access to. A lot of things that when I was working in the city, I realized that there was needs, but I felt like I didn't have the ability to make changes, just because you needed to have an academic appointment to make those changes. If you want to write grants and you get money for research, you have to have the ability to be a part of the university. And if you don't have a university appointment, there's no way to start, or so I thought. I also didn't really understand the bureaucracy of the health authority, the university, the social services system. But again, talking to certain people, the one thing that I learned is that there's always workarounds, and there's a way to sort of hack the system and get to where you want to be and make the change you want to make without having those structures necessarily, and without being sort of in with those structures as well. One thing that I've also learned through leadership is this slide, and I got this from Leonard Marcus and Eric McNulty, two of my teachers in the past when I did my MPH, and they always talked about leadership being in all directions, and I always thought that leadership was leading down. You had to sort of lead down, you lead others. But what they taught me was that you lead not only across your own organization, but you also lead beyond your organization to other organizations. You can also lead up as well to people who are in authority, figures of authority, people who are your bosses, people who are leaders and have positions of authority. You can lead up to them as well, and that you shouldn't feel shame in doing so. You shouldn't feel shy about doing it. You shouldn't feel scared about doing it. And in fact, many leaders do appreciate that too. So when I think of influence, I think of positive change and trying to make positive change, and that is always tricky to do. And also when I think of influence, I think about how do we make things happen? How do we make that change happen? And so I've got kind of two stories to share. When I first started, there were several things I wanted to do. There was a few projects I wanted to get off the ground that I felt that were big needs in our community. So when I worked with the Alex and people who are experiencing homelessness, I realized that often they would get discharged from hospital and they would just get kind of dumped at our shelter sites, and we didn't know what to do with them. And they were pretty sick. They definitely should have still stayed in hospital. But when you look at the hospital angle of things, that they would see that as being the exact opposite. It would be like, hey, you know what? They don't need to be in the hospital. They could just go home and get some bed rest and not and so, for example, if we had appendicitis, we would go to the hospital, maybe get an appendectomy or be put on antibiotics, spend a couple of days there, then told to go home without for bed rest and not show up to work. And that's easy for us to do. But if you're experiencing homelessness, you have no bed to go to. You have no place to end up in. And so one of the big programs I was trying to get launched during the time was a medical respite program that you guys have in Ontario. And that was at one of our shelters where people could go to as a post sort of discharge space, or even pre-hospital stay space to get rest and to recover and recuperate. So that was one of the big projects I was trying to get off the ground, but I wasn't sure how to do that. And I had a few other projects about navigating people out of the healthcare system, but I had a few projects that I had in the fire at all times, and I think that really helped ultimately to build connections and connectivity with others and others who believed in yourself, because as Yana mentioned, you want to be able to, you can't do things alone. You have to do things in a team. And by doing things in a team, you actually get to where you want to be. So the first sort of story I wanted to share, which is one of the rods that I had in the iron, is the NORS line. So this is the National Overdose Response Service. When I was in Calgary, again, I was sort of struggling, and I started to do some addiction medicine stuff before I went into formal training for that. And I was chatting with a patient, and one of our biggest issues that we're having in Calgary is that a lot of people are using alone. Almost 70% of people who are overdosing in their own homes by themselves. And I was just chatting with a patient of mine who was living in Grand Prairie, and I asked him if he had an naloxone kit and if he was using alone or not. He said he was kind of using alone. He kind of wasn't. I'm like, well, what do you mean? And he was like, well, I was FaceTiming my buddy in Edmonton. We were using together. And I was like, well, okay, if one of you overdoses, what happens then? He's like, well, we have each other's addresses. It'll be easy for us to dispatch, EMS services to them by just calling 911. And it was just such a brilliant idea. And just because of the stigma of addiction, he ended up not wanting to sort of drive the idea forward. He was really content with living his life with his wife and his kids, and didn't want anybody to know that the substance use. But again, a brilliant idea that I was like, this could be one way we could sort of mitigate the crisis that we're facing with drug poisonings. So in Alberta, in Calgary specifically, I was trying to get this idea off the ground. And I remember writing up a one-pager and going from place to place to place trying to pitch the idea. I showed up at the distress center in Calgary, and they didn't like the idea. They wouldn't even open the door for me. I remember trying to call the kids' help phone. I remember trying to pitch the idea to AHS, and it was really hard to get it off the ground. And I did luck out. This is, I guess, where circumstance kind of comes into play. But I had a chance meeting with an individual at a charity event who really took a liking to the idea as well. And the only reason I was at that charity event was because I had all these other projects in the iron or in the fire, I should say, going out at the same time. So I got invited to another charity event, and he was there, and he asked me what I was up to. I think Rita knows him, Mike True, Dr. Mike True, and he was like, he asked me what my ideas were, and I shared it with him, and he, as a mentor, was like, why don't I work on this with you? And I would really attribute a lot of what I learned from leadership because of him. He really sort of inspired me. He liked the idea enough that he helped me with my grants. He helped sort of connect me with certain groups and people, and to try to get the project off the ground. And we eventually did get a $1 million grant from Alberta Health Services to get this off the ground. And then sort of calamity struck, and the government at the time did not like the concept, the idea, and so they shut it down 8 hours before launch. So we were about to launch in Calgary, and 8 hours we got shut down by the government of Alberta, and it was pretty heavy. It was pretty heavy hit because the government was like, you can't do this. You can't create a phone line where people can call and use drugs, and so that didn't work out. But then going back to some of the principles that we talked about, when you really are passionate about a project, and even though your hands are tied, there's other ways to sort of work around it and hack the system. No one in AHS or the U of C or the U of A would have wanted to touch the program. They were like, we don't want to get the government mad. We don't want to, we don't want to agitate them. So we cannot help you. I remember like speaking to ethics and speaking to the dean, and I'm like, can you help me? And there was like a big no. But again, when there's a will, there's a way. And so leading across kind of came up. And so there was a group in Vancouver and a group in Hamilton, Ontario, who were actually doing something similar. One was creating an app around this. The other group had a phone line 2 years down the road as a not-for-profit that they were functioning in Hamilton, and very similar concept. And so we allied ourselves together, and we tried to make a large pitch. And I remember trying to track down people in Health Canada to talk to pitch the idea to them, doing cold calls and cold emails. And eventually we were able to reach someone who was willing to listen. And they heard the idea. They granted us a larger audience with all the stakeholders. So we pitched the idea. Then they sent us a document, and they're like, this is a grant template. Write us a grant, and we'll see what we can do. And it took some time, but we were able to get a $2 million grant to launch the program, and we're now nationwide. We've had 91 overdoses, 4,500 phone calls, no deaths, surprisingly. People all across Canada have been using the line, and we encourage them to use alone. And I think the sort of the thing that I wanted to bring across is that just always keep going at what you want to do, and take things one step at a time. And even if you fall down that hill that you're trying to climb up, try again, and don't give up. The sort of second story that I wanted to share was during the COVID crisis, and I think this is really a perfect example of leading across and up as well. I have this little quote here because this is another quote that Martin LaBrie told me. It was like, you don't, if you're just take one step at a time, and before you know it, you'll be halfway up that mountain. And you look behind you, and you're like, how did I get that far? And it's a quote that always lived with me, because every time I was trying to get something off the ground, I felt like I wasn't getting anywhere. And then you just look behind you, and you're like, wow, like I've made it so far ahead. How did I get here, and how did I make it to this point? So during the COVID pandemic, the very early stages back in March 2020, when things were not going as well, we didn't really know what we were dealing with. We realized that there was a situation with isolating individuals who were experiencing homelessness in our city, and no one was doing anything about it. Like, we knew that for the homeless population, that is, we knew that there was people who were working in the hospitals, people who are focused on long-term care facilities and giving guidelines around guidance around what to do or how to manage the pandemic with people who are living in homes. But within the shelter system itself, there was nothing happening. And we knew that because we keep reaching out to public health authorities, asking what's going on, and there was no response because they had their hands full. That was the bottom line. There was a lot of people who were really, really busy No one knew what was going on. And so a group of us, about 2 to 3 of us who were physicians, decided that we're just going to do something and just get something started. So we literally got together, put some pen to paper, stayed until 4 o'clock in the morning to plan out screening, isolation services, and try to put up a proposal to get a hotel up and running in Calgary in the beginning of March. And we didn't know if we had the ability to do that. We didn't feel like we had the authority. No one gave us the authority. We had no positions to make that happen. But we decided to do that. And so part of this was leading across within our own organization. So getting the Alex on board, getting my colleagues at CUPS on board, and then was also leading beyond to other organizations. So talking to the Calgary Drop-In Center, talking to all the other shelter sites, talking to the city of Calgary. The one thing that I learned from the situation was how to lead up as well, because we were by ourselves. We weren't really sure what to do. We just started doing. And I think that was a very important lesson, is that that we just, you shouldn't, you first don't work alone, but just, if you don't know where to start, just start somewhere. Like, just start doing it. Don't think twice. Just get started. And before you know it, HS was coming to us, asking us what we were up to and how, what's happening. And then we had the government call me. So we had the ministry start calling, and our chief medical officer of health calling, asking, what are you guys doing? What are you guys up to, and how can we help? And so before we knew it, we had, within I think a 3-week time span, the hotel set up in Calgary zone, and then all of a sudden we were able to help with Edmonton zone, and then we were able to help with Grand Prairie and Fort McMurray and different parts of Alberta to get these things up and running. And by leading up, it was all about having conversations, having pen to paper, showing them what you're planning to do, telling them that this will work because you know your population, being confident in what you know, and being very forthcoming with what your plans are. I'm trying to look at the time. I don't know how much more time I have. I think I've only got 2 more minutes. So some advice to new physicians. Things that I learned was that influence and power are 2 separate concepts, as was mentioned by Katie earlier. I always thought that you need to be in a position of power to create influence, and you don't. And actually, influence lasts a lot longer than power. People come and go from positions, but the influence that you make, the connections that you make, last a lifetime. So that was the one thing that I learned from this pandemic, from NORS, is that the connections that I made with all the homelessness sector in Calgary really helped out when we ran into situations. Those connections helped carry forward ideas, helped solidify ideas, and helped influence the government and listen to your ideas, because they're like, wow, the whole community is behind you. They believe in what you're doing. They're supporting you. We should listen to this person. And influence comes from not just above, but can happen across spectrum services as well. It takes a village. You can't do this alone. Every project that was successful has always been to collaborate with others. I can't take credit for everything because it wasn't just me. We all did this together in unison. And then also be a team player first before becoming a leader. One of the big lessons that I learned from others is that for those who just decided to do without doing collaboration, things failed miserably. You have to do it in collaboration with others. You have to do it as a team. You have to listen to others. Even though you think their idea might not be useful, there's things you learn by actually trying it out, and it's sort of keeping your own ego in check, and that's the thing that I've learned the most. So those are sort of my big pieces of advice. Is that these are like sort of the 4 pieces of advice. And never give up. Just keep trying to do what you want to do, what you believe in, what you feel, as Yana mentioned. Is not just for yourself, it's for everyone else, right? You're doing this for the community, you're doing this for others. That's so much more powerful than doing something for yourself. And that's what drives your passion, I believe, for most of us. And that's sort of my story.
Thanks for your words of wisdom, Dr. Ghosh. I will say, from an Emerge perspective, just a massive thank you for you and your team for the vision and the tenaciousness to get this across, because truly, I'm not sure what we would have done through the pandemic without the ACES hotels. It was an absolute game changer. So bravo. If anyone has any questions, you can feel free to pop them either in the chat box, or you can even raise your hand feature and unmute yourself and ask. We'll give everyone a couple moments here to ask Dr. Ghosh any questions. And if not, we also do have our Q&A session at the very end for our speakers as well. So seeing no questions or hands for right now, I'd like to just introduce our next speaker, Dr. Rita Watterson. Dr. Watterson is a general adult psychiatrist in Calgary. She provides both inpatient and outpatient psychiatric care to the city, and she received Calgary's Avenue Magazine's Top 40 Under 40 Award in 2018 for her work to advance mental health care in Tanzania with the organization Collabo. And so I'll hand it over to you, Dr. Watterson.
Awesome. Thank you so much, Katie. It's a pleasure to be here, and it's been so lovely hearing the words of wisdom from yourself and Yan, and hearing Monty's story. So thank you so much. As Katie was saying, I'm primarily an inpatient psychiatrist. I'm coming into my 5th year of practice. I also work in a number of different outpatient settings. So I worked at an adult psychosis clinic. I'm a psychiatrist at the refugee clinic. I run part of the day hospital service. I'm involved in PGME, work in Emerge, and then the side hustle is this Collabo project. And so that's primarily what I'll speak to today. And I think when I think about this influencing up idea, it really applied to starting Collabo, because Collabo was started in my 1st year of residency, so in 2013. And so a lot of the principles that Yan brought up, I think I'll kind of speak a little bit today, because I think those are things that really had to be utilized during those initial years to kind of like gain momentum and move the project forward. So Collabo is a project that's primarily based in Mwanza, Tanzania, and Mwanza is actually a city about the same size as Calgary. And they have kind of one primary hospital there. And when I went in 2013, I was in my 1st year of psychiatry residency, and I went there for a month with a fellow colleague just to kind of see what was happening on the ground. At that point, they had one psychiatrist covering an inpatient ward of 50 patients, a CL service, an outpatient ward, and clinics that would have 100 to 200 patients in a clinic, as well as community clinics. It's a catchment area of 10 million people. And so that psychiatrist there was very overburdened and drowning in work. And so she is trying to find solutions for her community in her department of how to make change, and how to be sustainable, and how to build medical education. And so, you know, I come from a background, I did an MPH prior to medical school. I focused on global health during that time, and had a global health focus during my medical school, but couldn't find a project that really aligned with what I wanted to be my skills and my knowledge, and something that could be community driven and have a real longitudinal relationship. I think global health really work should be kind of based around those principles. And so when I was there, we started to kind of have some meaningful discussion around what that might look like. We were very lucky in terms of circumstances that the University of Calgary had a long-standing relationship with that university, KUAS. And so those relationships and partnerships were already in place to kind of start to build something meaningful. And so with that in mind, I came back and a very close colleague of mine, Kimberly Williams, and I started to kind of think about what this would look like in practice. And we wanted to start to build a partnership that our residents and our department and our PGME program could really be part and parcel of. And so that needed a lot of thinking in terms of how we were going to influence and shape the thinking of the department, of our staff, of our PGME leaders, but why we would want to invest in a program in Mwanza, Tanzania, and what benefit that would have, frankly, for our department and for our residents and for our learning, that would be mutually beneficial for them moving forward. So I'll speak to kind of like that process in a second. Like moving forward, what has happened is that now this program has a staff of 5, which I know sounds very small still, but comparatively to one psychiatrist, it's quite significant, as we've been able to fund 3 scholarships to provide residency programs for subsequent staff. We've been able to go from having no UME curriculum within that university to them with collaborating to make a UME curriculum and now handing over that entirety of the UME curriculum. And so 250 medical students go through that program a year. And now that's going to be entirely taught by their program. And then in 2023, they're actually going to start their own PGME program. And so in Tanzania, there's only one program in the major city. And our trainees that have gone through have actually gone to Uganda and Kenya to do their training, because there hasn't been appropriate training within the country. So it's going to be a huge next step for us to help collaborate and make a residency program. So moving back to thinking about 2013, 2014, like what we're able to do, because the barriers at that time were really significant in thinking about how we're going to shift the perception of our colleagues in Calgary around why we needed to join this program. So one of the ways that we did that, and I think that's really important, is building the fund of knowledge to present to these stakeholders. And so we got funding to do an initial needs assessment and went back a second time with a bigger team to conduct interviews, to do questionnaires, to meet with all the stakeholders within Tanzania around what a project could look like, what they need, what they want to get out of it. And that was then compiled into quite a significant report that we were able to kind of like hold on to and present to our those people in leadership positions. And so I think you need to think about the data that you rest on, and especially when you're kind of potentially a resident or kind of early in our career, we want to be able to know that background to give our rationale as to why we're doing what we're doing. And I think for us, that needs assessment was able to kind of capture that piece. I think a second piece that we did quite well is we brought in a number of key stakeholders. And so as we were early residents, we needed to find staff that were keen in this area and able to give their own time and service to something like this, but also had a fair degree of authority and clout within the department, so that when they were able to put their name behind this, then it would be able to carry weight. And so I think for us, that came with like a number of lots of different conversations, just like trying to seek out staff to be able to latch onto the Collabo project. And we were very lucky early on as to who wanted to be engaged with the project. But it meant like, after residency teaching, like someone mentions global health, like we're there at them, like having that conversation about why they need to be involved in Tanzania. Or if we catch someone in an elevator and they say they're interested in traveling abroad, like we would start talking about the project with them. So anytime we had that opportunity to kind of bring key staff in, we would do that, just because we know that it would really allow us to gain a lot of momentum there. I think the other piece that was really key for us being able to gain momentum and make those changes in terms of moving the project forward was finding who the change makers were in the number of departments that we worked in, and getting those change makers who thought really innovatively, who could understand the concepts that we were talking about, kind of like at the table, so they could think about from a higher level how they would want to move this project forward. And so we were very lucky at that time that our head of department psychiatry was very like-minded, and she kind of grasped onto that project, and we really kind of like always ensured that we kept her up to date and knowledgeable about what Collabo was doing, so that those change makers were really involved. I think, and then another barrier I think that we found, I think a lot of projects find, is those financial barriers, especially for a project that's based overseas. I think it can be really challenging to find funding for that. And I think you just have to become really innovative and be willing to really do the hard work. I think Monty was kind of speaking to that, kind of like making that step-by-step change. And so like if we had to run fundraisers ourselves, we were doing all that kind of stuff at the forefront. We were sending out lots of different emails to anyone who was willing to kind of fund these sorts of things. We were reaching across departments. We were trying to find support. And so I just think in that way, we're trying to be creative as to how we found funding, but also realizing we might have to do a lot of heavy lifting ourselves. You know, when I think about those principles that Jan was talking about, and then Katie, you talked about too, I think there was a lot of things that we kind of leveraged in terms of being able to influence up and move the Collabo project forward. So for example, that concept of reciprocity. So we were able to do that because we were able to demonstrate that the PGME program in Calgary didn't meet the needs of vulnerable populations and global health and kind of learning about those objectives. And actually that there was a bit of a scarcity and deficit in that area. And so by being able to demonstrate that we would be able to fill that gap by having residents involved, then I think that made it much easier for the department to bring on this project. You know, dozens of residents have been involved in Collabo. We have a chief resident of Collabo, and we actually try to make it quite resident driven, so they're able to take on these leadership positions. And that has been seen as quite a benefit because it's been able to fill the gap of the PGME program in providing that sort of training. And so therefore it makes it much easier to pitch funding and time away and all these different sorts of pieces. As well, like that piece around scarcity, like Collabo is now one of a few projects across Canada that's able to provide this training within psychiatry, and demonstrating that is important because it actually draws a lot of residents in CARMS. It's a thing that's pitched for us in Calgary. And so that's another reason to be able to get people hooked into the project and get our department on board. I think as well, we really tried with the key stakeholders to build mutual respect, because we had not only those kind of like key stakeholders of a number of psychiatrists and leaders, but also recognizing that both Kim and myself in those early years, we had a lot of experience within this field and we could bring that knowledge and background to it. And so I think there was a degree of mutual respect that we were able to kind of like leverage as we moved this project forward. So when I think about like the key learning points that I've been able to kind of take away from being involved in Collabo as it's grown and gotten bigger over these years, one thing I think about is the importance of preparation. And so when you're thinking about meeting with stakeholders, leaders, department heads, whatever, you know, that may be, really the important of, as a psychiatrist, I think about like our DBT and CBT skills. And so one thing you can do is like think about your scripts for what kind of difficult conversations are going to look like. Maybe talk them through with a colleague, maybe write them down, play it forward, think about like if it's going to go this way, that way, you know, work out all the different scenarios so that you're able to talk through some of those things. And I know for me personally, that was a skill that really was quite helpful, so that when I did have some difficult conversations, it allowed me to stay quite regulated and on point. As well, like, you know, hearing Jan talk about some of the really challenging feedback that you can get as you move projects forward, I think it's important to really build kind of a network of trusted allies and people that you really care about their opinions. Their feedback is really important to you, and that you have that really strong relationship built on trust. And then the other voices, let them fade into the background. Like, don't let that other stuff kind of like get in your forefront, because otherwise you won't be able to move the project forward like you would like to. And I certainly, like, in moving forward a global health project, that, you know, a lot of people ask the question, like, why do that in the first place? I think you got to be very wary of those unhelpful voices, and where we got to really park those in the background. And then I think, like, as early staff, as residents, you just got to trust your experience and knowledge. You have a lot that you already have, and that you can demonstrate that through that there's a lot more common ground than you could probably imagine there is. And so kind of trust a little bit of that intuition there. Lastly, I think the points around advice to give moving forward. So I'm now 5 years out, like this is kind of a little bit of a more challenging time, and because there's a lot of different balls I have to juggle at times. And, my work, my kind of like side hustle, family, all of these kind of obligations are kind of balls in the air. And when I think about that, what it comes to mind is the importance of value-driven work. So you really should be managing your time and thinking about your time, about what is important, like what makes you happy, what gives you meaning, what gives you pleasure, and your time should be directed to those things. And so for me, it was like very clear early on in medical school and residency that I wanted to be involved in something like this. And so for me, that makes it very easy to kind of like designate time to a project like this. And so just thinking about that, it's important that your work, because you're going to be pulled in so many different directions and asked to do a billion different things, that it really be value driven in a lot of ways. I think as well, I've pushed myself to think about a growth mindset rather than focusing on kind of like the deficits that I carry and focusing on the fumbles and the difficult challenges. And instead thinking about when I have setbacks, when we have a team has setbacks, when Collabo has setbacks, how can we grow and learn from these opportunities? Because I think if you can shift yourself to that growth mindset, then you're really going to be able to build a lot of momentum and learn from things that have gone wrong. And so like I personally try to really recognize my blind spots and the kind of distortions that come up for me, and being able to do that and recognize that stuff and then just being able to grow, I think has been pretty effective. So yeah, I think that's probably all I was thinking about covering during that time. So maybe I'll hand it back to you there, Katie.
Actually, Dr. Watterson, I'll be thanking you. So again, this is amazing work. I actually realized I'd heard about Collabo through the work of some of my friends who are in psychiatry. So that's fantastic. And thank you for giving us your advice and lessons that you've learned along the way. The importance of preparation, finding a group of trusted advisors and letting detractors fall to the background, spending time in a values-based manner, having a growth mindset. Those are definitely lessons that I and I'm sure many others will find useful as well. So I just want to take the opportunity to let our attendees sort of kind of digest kind of all the wisdom that has come our way. And if anybody has any questions or follow up in the chat, now is your chance to pop them in. And just looking at chat, definitely, yes, this is our first Influencing Up session. If you can please give us feedback on how we're doing, we'd love to hear from you. And the link is in the chat as well. Nikita, you're welcome. Thank you for turning on your camera so that we can, so at least I can see if I'm confusing you or not, because my speech is not as eloquent as Katie's. Oh, Stephanie asked a question. How do you balance, by the way, Stephanie, it's good to see you here in this group. Stephanie and I work together as part of the CMA practice management curriculum here. How do you balance your side hustles with your financial wellness, assuming that you're not making much from doing these side hustles in the beginning? So that question, I think, goes out to Dr. Watterson, but if Dr. Ghosh has any insights, or if Dr. Damji as well, feel free to answer. So Dr. Watterson, would you like to take that?
Yeah, Stephanie, I think that's a great question, and I'm glad you bring it up. I think all of us are doing some degree of side hustle or some degree of work that's underpaid or not paid. And I think you just need to think about the juggle and how much you're willing to take on the side hustle versus how much, where your values lie in terms of what you want to be doing for the majority of your work and where you ultimately want your income to land. And so, I think I've landed that collabo can't take up all my time. I can't make $0. But it can take up, 10 hours a week or 5 hours a week on these weeks. I think I really ensure that I'm very mindful of how much time it takes up. And simultaneously, I think I'm also very mindful about what other work I pick up that does bring income and what kind of income it's bringing. And does that balance out the objectives and values that I'm trying to kind of continue to bring? Does that answer your question, Stephanie?
Yes, it does answer my question. Thank you.
Yeah, okay. I wonder what others think of that.
I mean, that's the part that I juggle with the most as well, is how much, how do you spend time doing this and at what cost, right? Because I could easily make more money by working more hours instead of going into meetings around the things that we're working on. But it comes to what you're willing to sacrifice and what your passion is. At least that's for me. And I love the project so much. I feel like I'm making a difference. I love the people I work with, that I'm willing to take a hit. And I mean, the alternative would be doing an ARP in the future. And so if you're really into this kind of world, juggling administration, research, innovation, applying for an ARP would be very helpful. If you're ever doing innovation, try to make sure there's a research tint or tilt to it, which would be beneficial for your ARP, as opposed to just program implementation. But yeah, I think that would be sort of a way to sort of mitigate that and work around that and marry the two. And that's what a lot of my colleagues have done. Oh, an ARP for you Ontario people, that's the alternative reimbursement. So it's a salary basically from the university or from an academic center. And it doesn't necessarily need to be from an academic center. The thought process is that you need to have one from Alberta Health Services, for example, or Health Authority or the academic center. But there's lots of not-for-profit agencies that offer ARPs as well. So definitely look into that if you can. But yeah, that is an option to help sort of mitigate loss of income to do what you want to do.
I think the only thing I would maybe add to that as well is that sometimes, when you're initially trying to get something off of the ground, depending on what it is, there is likely a large component of, work that you're putting in that's unpaid, but that doesn't mean that's going to be the case for the long term. So sometimes, your innovation or your initiative that you're doing may eventually lead to something that, could be funded by, your funder, or it could be funded by, your institution, your hospital, your university, and you might be able to eventually get some remuneration back as well for the work that you do. So I know that was the case for me, and I'm going to talk a bit about that in my remarks around the assessment centers and some of the work that I had done there. So that was the one thing too that I noticed in that journey, was that eventually it started off as being entirely unpaid, but eventually did transition into something that was paid.
Thanks, Dr. Damji, and thanks, Dr. Watterson Ghosh, for your answers. I hope that is a good, thorough set of answers for you, Stephanie. Thanks for your question. And with that, that's a good segue onto our last speaker, Dr. Ali Damji. So Dr. Damji, full disclosure, great friend of mine. I'm very excited to be introducing him. Dr. Ali Damji is an academic family physician and addiction medicine physician. He's also the COVID-19 medical director and QI program director at the Credit Valley Family Health Team and Family Medicine Teaching Unit, and Halton and Mississauga Rapid Access to Addiction Medicine Clinic. He's also an assistant professor in the Department of Family and Community Medicine at the University of Toronto. So he's bravely joining us from Ontario tonight, where it's past 10 p.m. And also serves as the division head primary care at Trillium Health Partners, and was the former physician lead for THP's COVID-19 assessment centers. Dr. Damji and I were actually in the College of Family Physicians of Canada's section of residence together back in the day. And I've actually seen him put his considerable influencing up talents to work multiple times to great success. So I'm super excited to hear what he has to say. And with that, I'll turn it over to you, Ali.
Well, thanks so much for the kind introduction, Jan. And I'm so honored to be here with all of these panelists and wonderful people, and also to be part of your panel today as your friend. So thank you so much for that. I'm just going to quickly share my screen here. And so, just to add a little bit to Jan's very, very kind introduction, to give a little bit of context for myself as well. So in terms of where I am in my clinical journey, I'm in my 3rd year of independent practice. So I finished residency in 2019, and I'm now just about to enter my 4th year of practice, with a balance between addiction medicine and my family practice as well, and medical education, quality and innovation, and health system leadership being really important aspects of the work that I do. I am fortunate as well too that I do work in a almost like ARP type model. For us, it's a family health organization model for people that are from Ontario. So it's almost like a salaried type model in an academic unit. So that's been very helpful in terms of being able to participate in these types of initiatives that I've gotten involved in. And so, in terms of whenever I give talks or when I tell people that, I'm currently now the division head of primary care for our hospital, and Trillium Health Partners is one of the largest community hospitals in Canada. And, as division head, I'm responsible now for all of our family physicians, kind of functioning as their chief and their director. There are many times where I have a lot of imposter syndrome, especially being, 3 years out and, having this role and having to do these different things. And so I often ask myself, how did this happen, and how did this journey kind of unfold the way that it did? And I think that influencing up has certainly been a large part of it. I think that I've been fortunate in terms of building connections and working with really incredible people that have mentored and supported me to get where I am today. And so I'm going to be sharing a little bit about that journey, and also some highs and lows in terms of that particular journey and what I learned from that. And so this is an example of a low. So those of you who may know me from Ontario and my history as a medical student may have found out about that story. And maybe even those of you from out west may have heard about this story because it was so prolific when it happened. So this is essentially a snapshot of something that happened to me when I was in my 4th year of medical school. And so I was one of the co-presidents of the Ontario Medical Students Association. And at that particular time, it was a very controversial time in Ontario in 2016, 2017, where there was a controversial tentative physician services agreement, a lot of disagreement in the profession at the time, a lot of conflict. And then there was also a big, governance renewal that happened within the Ontario Medical Association in the aftermath of that particular vote. And so, as the president of the Ontario Medical Students Association at the time, we decided as a board to endorse that particular physician services agreement, and that put us in opposition with members of the physician community who got quite upset with us about it. And so, as you can see, eventually these things escalated to the point of actually turning into threats and personal attacks. And at one point, I essentially was having my CARMS match threatened by individuals who were quite upset with the stance that I was taking on behalf of the students and the leaders that I was working with. And so, as you can imagine, like, this is kind of the, classic example of being in a position of relatively without power. And I think many of the residents here may relate to this in terms of, when you're faced with a situation like this, that's clearly wrong. You want to make an impact, you want to make a difference, but you feel like any move that you make could essentially end your career or put you in a really compromised position. And so this was a really, really early lesson for me in terms of the power of influencing up and how to do that effectively in a way that was able to allow me to still, save my career and actually enhance it and turn the situation into something positive and an opportunity to advocate against bullying in our profession. And so I'm going to talk about that shortly, but I just wanted to kind of set the stage a little bit with that one. In terms of what I think influence is to me, is I feel like it's that ability to move people, move their ideas and your organizations and community, and even an issue itself. And like we were talking about earlier, it's not about compelling people, but it's about altering people's perceptions so that, they may be able to see your point of view. And I think that the important thing about influence as well is that it's something that we can build over time. And so I found that, I started off in that particular position as not being particularly influential in the space, but over time, I was able to build that influence because of several key principles. So going back into these stories, advocating against bullying as a medical student, what essentially happened in that particular scenario is after these messages started coming in and it started to feel quite real as a fourth year medical student that this could potentially cause harm to my career, is that, I tried to make sure I got the support that I needed. So I reached out to mentors. I reached out to, different levels that I could, whether it was within my university and beyond that as well. And one of the reflections I had as a student leader at the time was how privileged I was because of the fact that I had those connections and I had the ability, because of a leader, to actually access those people. And one of the things that horrified me when I spoke with some of my colleagues at my home university, and when I spoke with some of the leadership there, was that they told me that this particular incident that had happened to me was something that they see relatively commonly, and that it's not, a one-off occurrence that this had happened, but actually something that they had a process and procedure for because of how commonly these things happen in medical education. And to say the least, I was quite disgusted when I heard that, because of the fact that this could be happening to, my colleagues all around me who very well could be suffering in silence, terrified before match day around being threatened by their preceptors. And, there being really little conversation about it, and that this being accepted as the status quo. And so for me as a leader, I felt that it was important for me to try and influence up. And while I was in a position of relatively lower influence, yes, I was a student leader, but at the same time, working in an institution that was already kind of coming down on me and seeing that quite firsthand. At the same time, I felt that I had a duty to try and make this better and try and use my experience and what I had learned to make a difference for my colleagues. And so what I did in that situation is I really tried to galvanize support and create a vision around this. And, one of the biggest things when you're thinking about influencing up is figuring out what your why is, figuring out what it is that you're passionate about. And I know my colleagues have spoken about values, and that's a very, very important place to start. And to me, that value in this scenario was the fact that it just simply wasn't right that our medical students and trainees could be bullied and intimidated like this, and that could be seen as something that's okay. When we think about some of the earlier comments made as well by our hosts, when we think about the sustainability of our healthcare system, it's also a health systems issue, because we know that if medical students are bullied, they're then going to turn out to be bullies when they come into practice, and it just perpetuates the cycle. And when you think about reporting of errors, when you think about when things go wrong in conflict, all of these things are exacerbated by the culture of harassment and intimidation. And, we know that a safe healthcare system cannot function if there is bullying and intimidation occurring in that environment. We know that that's going to lead to harm to our patients and to our colleagues. And so when I was coming up with my why and my vision, it was really important that I emphasize those points as well, because as my colleague said, we needed to make it about the broader group. It couldn't just be a medical student issue. It had to be about the broader system as a whole. And what I found was that when I did that, it brought people in, and it brought people in that you would expect, but at the same time, it also brought in some unexpected voices as well. So we saw our regulatory colleges get involved, and that they wanted to help support the work that I was doing around advocating for this. We saw the medical institutions and the medical schools all rally around this as well. We saw professional associations, including the CMA, actually, that stood for creating a code of ethics and incorporating civility into that particular code. And I got invited to actually contribute into that work. We saw the Royal College and the College of Family Physicians of Canada inviting me as a speaker to try and actually elevate this platform and this dialogue as well, to be able to share what was going on with our leaders across the sector. And so when you create a vision like that, what I realized is that when you make a really big encompassing vision that's about the future of the healthcare system, you can then start to attract partners to you. And I found that was extremely important during this particular low time to be able to do that. And for me personally, to know that all of these institutions and organizations were interested in my story and also wanting to make sure that it didn't happen to anyone else ever again, that was huge for me in terms of making myself feel a bit more confident as I got towards match day. In terms of some other things that I learned from that, I also realized that influence really can snowball. And so, those conversations that you have, with one-off people, whether it was a mentor who, I just trusted as a colleague that I could open up to the registrar of the CPSO, I found that influence continually snowballs. And so one of the things I always encourage people to do is to be open, have conversations. If someone wants to meet with you, even if you don't think it's really relevant, just meet with them, because even if it's not relevant at all, you'll still make a really amazing connection, and they may know people that actually are more relevant and will help open doors for you. And so one of the things that I learned as well in that experience was that, there was no one who was irrelevant in this story. We were all part of it, and that I was open to meeting with all of those different people. And then I found too that that also helped with getting the story to an even broader audience. So at some points, the story even made it to the public, and we were able to put out news articles and other pieces around the fact that bullying in medicine was unacceptable. And again, that wouldn't have happened if we hadn't reached out and if we hadn't tried to make this a bigger movement than just medical students. And so in the end, when I think about some of the impacts, certainly there's still a long way to go. And I know that, many of my colleagues continue to suffer these types of instances. But I do know as well that we did push the needle somewhat. I did notice that after this incident happened and the different advocacy and talks that we gave and the organizations that became involved, as we saw some real tangible action. We saw the CMA incorporate things into their code of ethics around intimidation and harassment. I saw during my chief residency orientation, when I eventually became chief resident, that we had sessions around how to support our learners when there is a culture of bullying and intimidation. And I even noticed in my own sites that when we've experienced situations like this within our university, the response from other faculty was very, very different from what I witnessed when I was going through as well. And to me, that makes me really happy, because it makes me realize that in some ways, this movement did create an impact. And then, to switch gears a little bit around influencing up, another situation I was put in my first year of practice was I became the de facto leader of the assessment centers. So, it's one of those situations where, again, saying yes to opportunities, with an asterisk that you never want to burn yourself out. But, of course, pick and allocate your time wisely, as Dr. Watterson said, but certainly be open to experiences and new challenges in your leadership. And so this certainly was one, because I was, brand new in practice in my first year, but my leadership skills, partially because of some of this advocacy I'd done around, harassment and intimidation and bullying, people had seen me at different stages advocating around this issue, is that I was invited to help lead the assessment centers. Now, this was something that was unfunded at the time. We were really trying to innovate and try and create something that worked in our system, because for context, where I work is Mississauga, Ontario, and that's in Peel region, which was one of the hardest hit regions in this entire pandemic. We have a lot of essential workers that work in Peel region, some of the largest plants for Amazon and many of these, places that deliver things all over the country are located in Peel region. And so we were heavily, heavily hit by COVID. And so what became very clear early on was that we needed to innovate, and we needed to innovate fast, and we needed to create some sort of system that would be able to balance the fact that we had limited human resources. We had a situation where we had limited access to PPE at that particular time in the pandemic. We had a lot of uncertainty and a lot of fear about what was going on among the community, but also even amongst our colleagues and physicians, nurses across our organization. There was a lot of fear and uncertainty because this was a brand new virus, and none of us really knew what we were dealing with, and we were all learning together at the same time. And on top of it, we were also in an environment where the healthcare system at its baseline was already under a lot of strain. And, we're seeing it now where you add the extra pressure of COVID and other factors, and the system was already starting to buckle. And so I came into this role, and asked to help lead this team of physicians, many of whom were senior to me, because again, I was in my first year of practice. They were interdisciplinary as well too, because of the fact that the COVID assessment center work had physicians from every department volunteering and stepping up to contribute their time. And so, we had everyone from radiology to anesthesia to surgery to medicine to family practice. Everyone was, jumping in to help out. And we were all this brand new team, and I was the leader of this particular team. And so for me, it was definitely a situation that was ripe for imposter syndrome. But again, I tried to use the principles I had learned when I was in that medical student situation, to recognize who my allies were, who were my potential resistors, and how to actually lead change within an organization and galvanize support. I developed a vision around, what our assessment center could be and what could our potential be as well. Not just could we be, trying to do things the way that we used to and that we'd always do in terms of, having a stand-up assessment center, but what about also trying to do things differently, like using virtual care? What about developing a virtual assessment center where we could actually assess patients from their homes and then just bring them in for the swab if they met criteria? And if they didn't meet criteria, save them the trip of coming to the hospital and potentially being infected. What if we decided to develop an outreach program where we work with public health and we work with primary care to try and support those efforts? And again, using my own background as a new in practice doctor, I actually used that to my advantage because I knew so many aspects about how the system worked, because as residents, we rotate through so many different parts of the system. And in some ways, that actually gives you a beautiful bird's eye view of how everything works. And you're able to see connections that perhaps people who are, in practice for years and years and years in the same part of the system, they may not see it that way. And I found that was really, really powerful when I was in my role, because I was able to build connections that we otherwise may not have thought of. And then the fact that, I was in my first year of practice, I also used to my advantage, because when we faced uncertainty, I acknowledged it as well. And people understood that, someone in their first year is going to be uncertain as well. And I certainly leaned into that. But then I also brought people along and I said, how do we solve this problem together? And how do we lead change together? And so I think a really important part of influencing up and getting people to believe in you as a leader is making sure that you are an inclusive leader that's willing to hear from them and to recognize their experience too and their unique perspective that they bring. And I think that's a key difference from the hierarchical power structures. And I would argue is much more powerful. And so in terms of how things turned out, we actually were really successful with our assessment center, to the point that we were actually even recognized within the hospital as well. And so we developed a virtual assessment center that saw tens of thousands of patients, avoided so many potential in-person visits to the hospital, and was able to support the hospital at a time that was so crucial during the pandemic. And we were really grateful that amongst over 50 submissions, we were selected as the top Sustainable Innovation Award for that particular year. And that was an award that was presented to our entire team, which we're super proud of. So in terms of my key takeaways, the first thing is start with the vision, know your why and communicate it, because ultimately that's what's going to attract people towards what you're trying to accomplish. You don't need a position. And so I know my colleagues have said that as well. And I certainly believe that too. There were multiple instances in the examples that I said where I didn't have a lot of power. And I had to kind of build that as well. And that's where you're able to actually become a powerful advocate, is by generating influence. It's not by having a position. So, a position only goes so far, and really you do need to try and leverage those connections and build that influence, because that's ultimately what will lead sustainable change and get people to believe in you. And even if you have a position, you still need influence in order to be effective in your position too. So it's not one or the other. You really still need influence. It's ultimately the secret sauce. You need to plan ahead as well. So find your allies and know your resistors as well. And even with your resistors, have an open mind. And I love that line that Jan used earlier around the fact that you want to see the good in what people are bringing. And even if they seem as though they're resisting your ideas, there's often a perspective behind that too. And certainly I had some challenges when I was leading this group, but I actually learned a lot when I actually sat down and had a conversation and found out what people's challenges were. And it actually made the program much better. Certainly networking is crucial, and mentorship is also crucial. I would not have been able to accomplish what I wanted to accomplish without the mentors and the people around me. And I'm ever grateful to them to this day, because they certainly helped me at a very, very dark time in my career. Your junior perspective is an advantage. So, please don't have that imposter syndrome or feeling like you don't belong there, because as Jan said, that ultimately shoots you in the foot. If you believe you don't belong there, people are going to believe that too. So you really need to recognize that your perspective is an advantage there. And remember that bird's eye view that you have, because you're working across the entire system simultaneously, which very few people do. And again, if you have that imposter syndrome, lean into it, because sometimes it can be a helpful, sober second thought as well. And it certainly saved me a few times when I thought about, am I missing something here? Should I maybe check this with some of my mentors? And that is very helpful. And people will relate to that. People will understand you. If you acknowledge your uncertainty, and lean into that imposter syndrome as an advantage, people actually will respect you for it as well. And I found that during the case of COVID, that when I acknowledged situations where I was uncertain, people did respect me for it in the end as well. And we were able to navigate that uncertainty together. And that made me a much more influential leader, and ultimately was one of the things that actually drove them to want to recruit me as division head of family medicine after I finished that role. Staying humble is crucial. So again, making sure that we maintain that humility in all that we do, and that will make you a more influential leader. Building bridges is important, but I'd also argue that maintaining relationships is important too, because influence, as we've all alluded to, is based on relationships that you have. And so one of the things that I always try and do as well is really try and connect with people that I've previously connected with. And even it's informal stuff as well too, because as you become more influential, yes, being liked is not, ultimately one of the most powerful techniques, but it does help as well too. And if, you spend the time to over time nurture and cultivate those relationships that you have with others, it will build your influence as well. It's not the only way. And I totally agree with what Jan said, that, it's not the first method that you need to do, but once you've started to establish yourself, building and nurturing those relationships and connections can actually go very, very far. And then again, I would just echo what Dr. Watterson said as well, maintain that consistent growth mindset. Failures I like to think of as a first attempt in learning, FAIL. And I think that that's truly a mindset that we can all take when we think about influence and innovation. And lastly, I know that we always talk about, saying no to things, but I think in an influence mindset, it is important to say yes, but I do put that asterisk there that our time is limited and you will need to be selective of it. But that being said, if this is something that you're passionate about, that you're willing to put the time into, that, financially you're able to support, because financial wellness is very important. Be open to new experiences and to learning from others, and also really keeping that broad mindset of, yes, this person may not seem directly involved with what's happening, but they still may be someone who I can learn from. And if not, maybe they can build a great connection and relationship that will come in handy down the road. And so I'll leave that there. Thank you so much. And again, I'm so inspired by all the work that residents do. I work with them so regularly as an academic physician in a medical teaching unit. So thank you for all you do. And thank you for attending the session.